Hello and welcome to episode 355 of the Thriving as a Physician podcast. I'm your host, Siobhan Key. Super excited you're here. I have a really fun and very interesting interview for you today. I'm joined by Brian Baumal, who is a registered psychotherapist working out of Toronto, and we're talking about cognitive behavioral therapy as a tool for understanding your eating. And so he goes into lots of tips and approaches that he uses with his own clients on how to apply principles of CBT to understanding your eating and feeling more in control, which is really powerful. And CBT has lots of evidence for helping with behavioral change like this. So let's just get straight to the interview. All right. Hello and welcome to the show, Brian. I'm super excited that you're here. We were just talking before we hit the record button about we've both been in a very similar realm of interest and expertise for approximately the same length of time, and yet have never crossed paths before. And we're both Canadian. So I'm really excited about today's topic. But can you introduce yourself to everybody?
Sure. It's a pleasure to be here, Siobhan. My name is Brian Baumal. I'm a registered psychotherapist in Toronto. I focus on a number of related areas. I focus on weight management, but I also work with all forms of eating disorders. I work with food addiction, and I work helping people and supporting them through bariatric surgery, use of GLP weight loss medications, either before they engage in these processes or during or after. I use generally a cognitive behavioral therapy approach with my weight management. That's probably about 70% of what I do. If I assess someone as a food addict, I may use an addictive approach. And with eating disorders, I may use a more psychodynamic approach. I think we're going to talk about weight management and cognitive behavioral therapy today.
Yeah. And I'm excited to talk about it because cognitive behavioral therapy is obviously something most physicians know a bit about, but most don't really have experience transferring it into their own lives. And even in practice, we as physicians, especially like primary care, where we have short little visits, chunks, we know there's beauty in cognitive behavioral therapy techniques, and yet don't always know how to actually use them in real life. And so I think this is going to be a great topic.
And I can just tell you one of the missing pieces from a therapy point of view is every brand of therapy, be it psychodynamic, acceptance and commitment therapy, DBT, CBT, has two components to it. We have the techniques that we use. Like, for example, in CBT, we have a thought record. In DBT, we have sort of wise mind thinking. And those are techniques. But often underpinning those therapies is a deeper philosophy. So a lot of the physicians out there and a lot of the general public understand the techniques, and that's perfect. But in some cases, we need the philosophy underneath them to really amplify the impact of the technique. So as we're talking, I hope to explain both the technique and the underlying philosophy of the CBT that I use.
Yeah, I think that'll be really helpful. Can we start with how you got into this area of interest? Because really, 10 years ago, I don't think there was a lot of people helping people with eating. Well, diets were.
No,
there were people, but in your way, the disordered eating wasn't talked about in the same way.
Well, the reason I got into it was because I myself had lost a lot of weight. And I use that term very specifically, lost a lot of weight. Because at the time, when I was yo-yo dieting and losing weight and putting on weight, I didn't even know I had an eating disorder. And I was a therapist at the time. So I remember coming to an inflection point in my practice because I wasn't liking doing general therapy. And I thought, what do I want to do? Do I want to specialize? Do I want to get out of therapy? And within 10 minutes, I realized therapist who has lost a lot of weight and kept it off for about 5 years at the time can help you do same. Like, okay, combine therapy, combine something I've done well, and away I went. But I started focusing on weight management, and then I quickly realized that many of the people that were coming to see me had eating disorders, and that
Hmm.
I had eating disorders, and eating disorders and weight management go together, and that we have to talk about both weight and disordered eating together, because most people, or I can't say most, but at least a number of people that come to my practice about weight management do have some disordered eating in their past. They may call it an unsustainable effort on their
Hmm.
part. They may call it strict adherence to diet or exercise. So I'm always combining weight management and disordered eating and food addiction together into one amalgam, if I can put it that
Yeah. And I just want to clarify, just because I know like physician ears listening, when you say
way.
many people have eating disorders, you're not always referring to like DSM-5
No,
eating
no,
disorders.
no,
You're
no,
talking
no.
more disordered eating.
Exactly. Yes. If I
Yeah.
did
Okay.
say eating disorders, I didn't mean to say that. I meant disordered eating traits, subclinical
Right. Okay.
eating disorders, one or two of the symptoms of disordered eating in their past, not necessarily full-blown DSM eating disorders.
Yeah, perfect. You know, it's really interesting because I kind of had a similar thing in that, you know, I started with obesity medicine, wanting to the science of like, okay, how do you actually help people lose weight? Like, I remember that being my sort of first question. And then as I worked with people more, I realized that it's not just hand somebody, you know, the meal plan and say, okay, let's all do this together.
Right.
That's kind of what I did the first while. It's really looking at, okay, when it's hard for them to follow that, or, you know, when they're putting in the work and they keep feeling like they're failing at it, what's going on there? And it sounds like that's kind of a similar way that then that's where I got interested in the, you know, why is it that why is it that all those questions, as well as trying to figure them out in my own life around the same time as well.
Right.
But it's just interesting that we had kind of a similar evolution.
It is. It is.
Yeah.
And I began to wonder what made me successful at my attempt. Now, I had studied psychology and therapy, and I know that that had something to do with it. But it wasn't until I started getting into the field where I began to really understand what made me successful at doing it, and what factors in my mind, emotions, my psyche, my behavior all sort of aligned together to allow me to manage my weight and my relationship with food and body, because they all go together. We can't say that this is just a weight thing at all. This
100%.
is a relationship with food. This is a relationship with body, both sort of our how we feel about ourselves and our overall physical health. So they all relate together.
Yeah, absolutely. I 100% agree. And I think it's where so many people get in trouble because, you know, society tells us worry about the weight and we take it too far, right? Like we worry about the number on the scale, not even necessarily
Well,
our body or our compositions or stuff. And we don't realize that all that other stuff is actually more important, I would argue, than the actual weight loss, if that's what somebody's going for. Because when you get the better body image and you figure out the relationship with the food, you can then, you know, I think of it like pulling levers. You can adjust levers over your life to adjust the weight piece of it if you need to. But
mhm.
if you only focus on the weight, you don't have you don't have that, not the levers, the foundational
Yeah.
like stability. That might be a good way of saying it. So
Oh, God,
sorry, I
yes.
didn't mean to interrupt you.
No, I mean, weight is just one factor in all
Hmm.
of this. And as a physician, I'm sure you're aware of it. I went to a medical weight management conference a couple of weeks ago, and I pilfered a slide from there. And you may have seen this before, but it shows a percent body weight reduction. And it does them in bands of 5%. If somebody drops under 5%, between 5 to 10%, 10 to 15%, and 15% or greater, what the metabolic impact of that is. And I can't remember what all of them are, but if you lose a certain proportion of weight, your cholesterol goes down, your triglycerides go down, your risk of mortality from heart disease goes down. Obviously, blood sugar and diabetes, the risk for that goes down, can be reduced. And that's what physicians are interested in. You're not necessarily concerned about the number on the scale as much as you are, okay, you've lost 10% of your body weight and your blood pressure has come down, and we can now rejig your medications or even think about coming off of them.
Yeah, I love it when we can take people off medications.
Yeah.
So
Now,
much
you know
fun.
what? I want to jump in because here's where we start getting things confused in our minds. And here's where things psychologically start to derail us. Because a lower blood pressure doesn't stop your insensitive uncles or your insensitive friends' comments about your weight. Your friend doesn't know that your blood pressure has come down and that you've come off of your medication. Your uncle doesn't know that. They're still going to look at you and they're going to point at your stomach and they're going to say, hey, they've got Ozempic for that now. You should try it. So a lower blood pressure, a lower cholesterol reading, a better glucose or HbA1c reading doesn't translate over to the people that shame us about our weight. So that's why we still have that focus on our weight, because to the people out there, the other markers don't matter and they're still going to shame us about it.
Yeah. And it's tough, right? Living in a body that's like a larger size body, it's something that is very visible. And I'm sure you know this, and most of the people listening have probably experienced this, but people commenting on it is often uncomfortable on either side of it. Like, people commenting on, are you sure you should eat that? And, have you thought about losing weight, is extremely hurtful and drives that shame. But also people commenting on, hey, like, you've lost so much weight. I still experience this. I had it this week when I went to see a patient, and it's still deeply uncomfortable because I'm like, how is my weight still a topic of a conversation? When to me, it was something that I dealt with a lot of shame around and was really uncomfortable with. And I kind of feel like it's a little bit in the remote past, and yet comments still get made where you're like, oh, okay, you're here again. We have to talk about it again. But it is interesting, specifically around body size and weight, how much there can be influences from the people around, and generally well-meaning people. I think there's sometimes where people are assholes or other words. But I think a lot of the time they are well-meaning, but it still is hurtful, and it still can leave the person feeling ashamed. My
view is no comment is a good comment, or all comments are not good, even if they are meant positively. And I learned this from my own experience. I will just say, in terms of linking disordered eating with weight and everything like that, one of the reasons I yo-yo dieted is that I had full-on exercise bulimia about 22 years ago. When I now know what I know about disordered eating, I was eating 800 calories a day, working out twice a day, getting dizzy, going from sitting to standing up. I mean, that behavior is pretty much full blown right there. But the comments I would get, because people would comment on my weight, and they fed me. They fed me. And then when they didn't feed me, I was like, oh my God, there's something going on here. Like, I remember my father saying, son, you look great. Keep doing what you're doing. And I wanted to say to him, Dad, I really think I'm caught in a cycle here that I can't get out of. I like your comments to me, but in order to get more of them, I've got to do some really nasty stuff. And these comments, so to link all this together, the comments can really play on our minds. They can drive us further into disordered eating. And on the other side of things, they can cause immense shame leading towards binging. And the comments are just absolutely hell overall. So that's why I tell people no comment is the best thing you can do.
You know, hearing you talk about that, I'm like, that would be a very good podcast episode in its own right. And maybe something we can plan in the future of like, how do you deal with people's comments? How do you, you know, live a life where you are managing this stuff long term and you know you're going to get these comments? And how do you deal with them without it derailing you?
Well, we will save it for later
really
because it will derail our whole podcast.
We need to talk about CBT.
CBT, yeah.
So talk to me about your CBT approach and how you feel, because we were talking before and you were saying you've really enjoyed it and you found it really impactful since you switched to more of a CBT approach. Can you just talk to us a little bit about your experiences?
Sure. So I used to practice psychodynamically, and that's the way I was trained. And it's a long form of therapy. And what I used to say was, I have an excellent track record if you give me a year of your time. Unfortunately, that's too long for many people. And the route is very circuitous. We're going to go into your past. We're going to go into your emotions and all that stuff. And I just decided to make a change in my orientation. And what I did was I certified myself in cognitive behavioral therapy for eating disorders. There is a very well documented protocol by Chris Fairburn, a psychiatrist out of the UK. His method has been around for about 25 years. It has been modified. It has been replaced. If you look at the research on it, it is effective in certain areas and is lacking in others. But nonetheless, it served as a very good template for me to learn cognitive behavioral approaches to eating. And then what I did is I modified it more for weight management. So in short, that's the genesis of what I did. And here's how it works. I think people, when they have issues following a good eating regimen, the reason why they get derailed from it is they have the following equation in their mind. First thing is, most people want weight loss to happen very, very quickly. And we'll come back to the reason why that's the case. But for example, now it is April 10th, and in Canada, in about 6 weeks, we have the May 2-4 long weekend. And I could picture a lot of people saying, I've got 6 weeks, I've got 30 pounds to lose, 6 weeks, 30 pounds. What is that?
Need to be in a swimsuit.
To be in a swimsuit, right, for the May 2-4 long weekend. It's 5 pounds a week, 6 pounds a week, whatever it is. All right, got that target, go. And they're really good for a couple of weeks. But what happens is life happens, okay? What derails them is not necessarily something deep in their mind, but rather they get sick. I'm getting over a flu. And maybe you can hear it in my voice. I will eat carbohydrates after I after I sort of hit rock bottom in my flu cycle. I don't know. It's just, I need them. And I don't go to the gym anymore. And it's like, people will say, damn it, I missed this week. I'm off target for this 5 pounds. I will never hit that 30-pound goal. I'm done. So you can get sick. You may have to care for a sick child. You may just have a really busy week at work. Or you may just realize, you may just have a day where the only thing that will help you through it is pizza or ice cream or whatever. You just emotionally eat. And all of these make us realize crap. I was going to say another word, but crap. I'm not going to hit my goal. So I'm done. And as I was developing this and certifying myself in cognitive behavioral therapy, I realized this sort of equation of quick leads to black and white thinking leads to failure, I realized that I had actually learned this concept about 30 years ago in managerial microeconomics in university. My professor basically said, if you are a manager, don't set your team's targets too high because they're never going to reach them. They're going to look at the target and they're going to go, that's impossible for me. I'm not even going to try hitting that.
Mm-hmm.
So this is a concept of when you set a goal too high, you're never going to reach it. This is a concept that spans a lot of different fields. So there's no deep psychology in quick leads to perfectionistic thinking or black and white thinking leads to failure. It spans many, many fields. Here's where the psychology comes into it. Because what makes us want quick results? Why? Why do we want the quick results? And the answer is shame. What we want to get rid of quickly, or what we want to make sure doesn't happen to us on the May 2-4 weekend, is we want to make sure that we don't get any comments from that insensitive uncle or that friend. We want to make sure that we feel good in our clothes. We don't want, on May 23rd, we don't want to try on our clothes from last year and realize they don't fit. Mm-hmm. Those are the things that we want to get rid of. We don't want to be the heaviest person at the May 2-4 long weekend anymore, because all of those involve shame. And the feeling of shame is incredibly difficult to deal with. So the full equation is shame leads to quick, leads to black and white thinking, leads to failure. That's the full equation that I use in CBT right there.
I'm curious because like with the people I work with, for a lot of them, the stuff that's shame sounds like fact because it's so like they don't even they recognize being ashamed of their eating and feeling like they blew it, right? But the some of the deeper shame stuff that you're talking about, I don't think it's always recognized as shame. It feels like it's just a fact about your body, about your size, about what you have to do that you haven't gotten yourself to do. And then the other piece that I find failure really interesting to look at and talk about because again, I think often people have like a blanket belief of it's just fact. I should have done it in this time frame. I did this instead. Therefore equals failure, therefore equals can't do it. And I'd just be interested in, as a psychologist, your views on those aspects of it.
Can you see the psychologist smiling? Because I've been smiling through all of this. Shame and fact go hand in hand. When you look at psychodynamic therapy, I know I'm talking about CBT, but when you look at psychodynamic therapy, or when you have an experienced therapist doing CBT, there are reasons why we don't, or why we don't confront this kind of thing directly, or rather, we don't challenge the facts. There are reasons why we don't challenge them it's because they are a fact. It's because, we'll have to edit it out. I got a notice so I'll just start again. There's a reason why we don't want to counter these facts because they are such entrenched facts in people. If I say to someone, oh, well, why don't you just reframe your thought around this? Or why don't you think about it in a different way? They're going to say, the reason I haven't thought about it in a different way is because it's a fact. It's a fact that I have always failed. And if you're just telling me to change my attitude and be more positive, Mr. Psychologist, Mr. Therapist, you don't understand me very well. And that creates a rupture in the therapeutic alliance that's very hard to break. So when somebody comes and says, it is a fact that I can't lose weight. It is a fact that I will always come back to this weight. It is a fact that after 3 weeks, I will fail. What I know is shame is operating at that point in time. What I will say is, I will say, interesting. Tell me more about what is going on for you. Tell me about the thoughts you're having about yourself. Tell me about the emotions that you're feeling. I will not cognitively restructure that thought, because to do that risks ruining the entire therapy relationship right there, because they do believe it is a fact. They do.
And it,
No.
for good reason, right? Like, because
For
it's
good
felt
reason.
like lived fact.
Right. There's a reason. One of the things you learn about working with very depressed patients, who often believe similar facts about themselves, like, I'll always be socially awkward, I'll never get ahead in a job, I'll never hold a relationship. You don't get into an argument with them, because they're going to win every time based on fact. And it's the same thing. It's the same thing here. And that's how my cognitive behavioral therapy works, because we have shame leads to quick, leads to black and white thinking, leads to failure. Now, we could treat the shame, we could treat the quick, or we could treat the black and white thinking. We could treat any one of those. And I've been practicing for 10 years. I've tried treating all three of them. I started by treating the black and white thinking and saying, this is black and white thinking. This is perfectionism. This doesn't make sense. Let's talk to your inner perfectionist a little bit. Let's figure out where this perfection comes from. It didn't work very well. Treating the shame, like I said, in a psychodynamic manner, takes about a year. But when you begin to treat the quick, and this is what I want to focus on, when you begin to treat the quick and say, all right, let's just slow down your expectation a little bit. And generally, I can get people to do that. People can say, yeah, I may not know the reason why, but I do know I want this weight gone yesterday. I do know that. Say, can you just draw the link? Can you draw the link between quick leading to perfectionism? They go, yep, I can. And can you draw the link between perfectionism leading to failure? They go, yep, I can. So I say, let's just slow you down a little bit. And that's where I do my cognitive behavioral food planning and food tracking. And that's how I get people to slow down. I say, we're going to take about 8 to 10 weeks or 8 to 10 sessions, slow you down and plan your meals. And here's a little trick that I use. It's not really a trick, but as they plan their meals, and as we talk about that, and Siobhan, you and I can talk about how I do that, but as they talk to me about their planning and their tracking on a weekly basis, my eye is on the shame part of things. So I'm asking very subtle questions about shame. So they will plan their meals, they will track their meals against their plan. And if they don't eat according to plan, which virtually everyone does, I would say things like, what are the emotions that come up? Do you want to give up right now? Do you realize that this is part of the slow process that we have to go through? How often has this been your pattern before? I'm subtly, very subtly addressing the shame aspects, and I'm not challenging their facts at all. I'm saying, what is going on for you in the factual experience of missing your target? Let's talk about that. It's a very subtle, and I think, if I pat myself on the shoulder, a very clever way addressing the shame in all of this. So they're talking about their behavior, cognitive behavioral therapy. I'm more interested in the shame thoughts and emotions brought on by that behavior. So that is, in essence, how I tie the shame to the quick and the cognitive behavioral aspect of things.
And how would you recommend, like, so for somebody listening and they're like, okay, I'm going to slow down, I'm going to give myself some more grace and time. How would you suggest they catch that shame? Like, assuming they're not working with you or with a therapist, do you have kind of techniques that you suggest people do at home?
Yep. So when, so I'm just trying to think for a moment. Um, I'm going to, before I answer the question, let me tell you about how I get people to plan their meals and track their meals. And
Okay.
then we'll come back to ways that they can recognize that shame is operating, because I think I have to explain the process a little bit.
Sure.
So, um, this is adapted right from the cognitive behavioral model for eating disorders. The way they plan and track their meals is the following. There are 4 aspects of any eating episode: what you eat, how much you eat, when you eat, and where you eat. Pretty straightforward stuff. We want people, as they slow down, to only focus on the when they eat and the where they eat.
Mm.
And I worked with physicians before, and I just make up examples that they understand. If they're working at a hospital on shift work or something like that, and today is a Friday and they're going to plan for Sunday, and their Sunday they're going to be in the hospital, and the only thing available to them is the hospital cafeteria, which, as most physicians know, is dominated by fast food, unfortunately, and Hortons and stuff like that. So the when and the where of their Sunday is going to be in the hospital, at the food court. And historically, they've always gotten an ice cap, a Tim Hortons wrap, and a Tim Hortons muffin. Historically, that's what they've done. That's exactly how I want you to plan for your Sunday. The when and the where, not the what nor the how much at this point. And if you know that you are going to a family member's on a Saturday, and that family member is documented in Wikipedia as serving the world's most irresistible brownies, then you go to that event and you eat 3 brownies. That's the what, that's the when and the where of all of this. And what people can fall off of this in a number of ways. For example, they could say, all right, it's Friday night. I've just come off of a 12-hour shift. I have some chicken breast that I'm just going to grill, and I'm going to have a good meal. And things are going to be great. You come home, a friend texts you and says, I'm outside. Knock on the door. Come on, we're going out for pizza and beer, and they literally drag you out. So you can fail at this plan many times. In the world's best brownie location scenario, they could send you home with a dozen brownies in a bag as well, and you eat those for a snack that you didn't plan. So there are lots of ways that you come off of this. And so that's initially how I start people on all of this. And here's where the shame comes in. So you can plan your meal and you can track it. And if you fall off, here's what I'm looking for. Do you immediately think that you're going to fail on your plan by having one screw up? If you do, shame is driving the bus. Does this cause you to just throw the rest of the plan away? Shame is driving the bus. Is this something that always happens to me? Shame is driving the bus in all of those instances. And the fact is, it's not. People think, people think that they've just failed, but in fact, they're just eating the way they have before. And that's a good place to start. It's a good place to start, is just tracking, or is planning to eat the way you normally do. And then over time, around 6 to 8 weeks, begin to make changes. as you track or plan and track and plan and track, you'll begin to notice patterns in your eating. The other thing too is after about 8 weeks of writing down, it's the same ice cap, it's the same muffin, it's the same donut in the hospital cafeteria. After 8 weeks of planning this is a bit absurd. Now I'm ready to begin to make a change. They do have a freshie over there. Maybe not the best alternative, but better than writing in a donut and ice cap, and so on and so forth. So after time, we begin to make changes in all of this. When you recognize patterns, when you recognize the absurdity of writing things down, and when you begin to recognize, oh, shame isn't driving the bus. I really couldn't do anything different at that point in time.
Mm-hmm. All of this is so good, and I have so many
I
thoughts
see.
in my heads and comments. But let's talk. Just so that's where you starting with the slowing down, which I think is fantastic and totally agree with. And what I'm hearing from your approach is what you're doing is you're taking away the restriction. You're taking away that knee-jerk reflex of, okay, I just have to change everything I eat.
Yeah.
And you're focusing on patterns and starting to see like the underlying, like, how am I eating? And not just like, what food am I eating, but like what situations and stuff like that do I end up eating in, which I think is really good. What happens after that? How does that feed into the rest of the equation?
Right. Okay. So what happens is they begin to make subtle changes in their eating. At the same point in time, I'm actually doing something that CBTE calls collaborative weighing. And I will ask people to weigh themselves and report on that weight. And I've got to give a big caveat here. I tell people, if you ever hear me say, yay, you're down 5 pounds, or boo, you're up 3, like, just hit the exit button, fire me on the spot. That's not the purpose of the weighing. The purpose of the weighing is to say, oh, you went up 5 pounds and you had a really good week. What's the feeling? Do you think you're failing? Do you think your body is conspiring against you? Kind of thing. Now, in the long term, when we combine the weight and the eating together, people begin to get a sense of their patterns over about 8 to 10 weeks. And they will realize their weight remains stable. They will realize their weight has come down a little bit. Or they may even realize their weight has gone up, but there's a reason for it. They can look at 8 weeks or 10 weeks worth of planning. From that point, they can say, you know what? My relationship with food and body is beginning to change, has changed. I see where all of this is going, and I now feel ready to do one of the following. I now feel ready to engage in an eating plan of my choice. I now feel ready to engage in a GLP-1 if I want to. Or they can say, I now feel ready just to keep going the way I'm going. There are people over that 8 to 10 week period that have lost maybe 5 to 10 pounds. And they say, you know what? This is a completely acceptable rate of change for me. I've made some changes. I'm happy with the way things are going. I'm just going to keep continuing the way I am. And I can support them through their transition to a GLP-1 or through to a more formalized eating plan, and support them through support them if they just continue the way they're going. But the end result is the relationship with food and body and the scale begins to change in a way that they can link all of this together and realize, yeah, you know what? Taking this at a slower pace does work for me. So I basically prepared them for any longer term change, which I can support them through. They can speak to a dietitian, a physician, or just continue working with me.
Yeah, which is excellent. And any other sort of like thinking for the physician listening who's really struggled with all of this, any other little tips or pearls you would have for them?
Couple of things for physicians. So I've worked with about a handful of physicians, and what I find very effective is that physicians do tend to be data and number and pattern oriented, and this works out very, very well for very well for them. If they, like I said, I will not track their weight loss or their weight changes and evaluate them or their eating. It's not what I do, but they can do that on their own. And oftentimes physicians will draw patterns from their eating. And that's what I find, that I don't really have to get into a lot of shame driving the bus with physicians quite so much. I'll say, what patterns have you recognized in this? Or in many cases, I would say something like, you're a physician, and your goal in many medical settings is to get their patient is to get your patient to their goal as quick as possible. You want that blood pressure down as fast as possible. You want that cholesterol reading down as fast as possible. You want that blood sugar reading down as fast as possible. Do you see a way for yourself to do that in the data that you have? So I found that approach to be very effective with physicians. And the other thing that I found too is that they can begin to think a little outside the box, more so than they normally would, because there are often treatment plans and treatment algorithms and treatment priorities that physicians follow. And I'm please feel free to jump in with weight management. The way people manage their weight and change their relationship with eating and food does not follow a standard protocol. If it did, we wouldn't be here. We would be following the protocol, or we would have the protocol and we wouldn't have time to do the podcast. It gets, the data sometimes leads them to the logical conclusion that they have to think outside the box a little bit.
Yeah, I totally agree. We wish there was a protocol. And when I say that, like, we as everybody who's struggled with this, it'd be so nice for somebody to send you a little flow chart and be like, oh, it's all fixed. Don't worry about it. Just follow this. But yeah, it doesn't work that way.
I have been managing my weight, my relationship with food and body for about 14 years now. I'm not at my lowest weight. I'll be 58 years old. Somebody asked me, they said, Brian, if you had to title this stage of your life as a chapter of a book, what would I be? And without missing a beat, I said, snap, crackle, pop, when my body makes sounds I never thought it would before. But, my knees are starting to go. I'm sure your audience knows what's happening to me as I hit close to 60. I do exercise 4 or 5 times a week, but I don't have the stamina anymore. And so I have to have grace with myself, or I have to make adjustments. And I think part of the protocol is to be flexible and understand that what worked for you 4 or 5 years ago may not work for you now, either because your physical health is changing, because your life circumstances are changing, or both. And you have to adapt and you have to be flexible. I've come to realize I will never be the lowest weight that I attained on this 14-year journey, because I don't have the stamina to do a 50-minute spin class anymore. I don't. Yeah.
I think, that brings up a couple points that I think are really, really important and missing from most discussions around eating and weight is like what you do now isn't what you're going to be doing in 5 years, because
Hopefully
there's so
not.
many different things that change, right? Like your body changes, medications may change, life may change. There's so many different things.
Uh-huh.
And however we approach it, it needs to be this concept of long-term management, which you just described really well. It's not like start line, finish line. It's, okay, we got here, and now, how do we keep us in the general area that we want to stay in, even as things change?
That's right. And physicians are in a really good position for this. I have a family history of high blood pressure. I have idiopathic high cholesterol, and I have to manage those. I go off and on the medications depending, but I speak with my physician all the time. So they're in a really good position to help someone that has a basic good relationship with food and body and weight, manage the metabolic issues with medications as necessary. And I can tell you, for me, that not having to worry about my blood, or when I mean not having to worry about my blood pressure, I mean I can manage it. It is managed. I don't have to have the existential worry of dropping dead from a heart attack, so to speak. Not having that worry is priceless. And knowing that I can go to a physician to get the help that I need is priceless for me as well. And knowing that I'm doing all that I can with my eating and exercise right now also makes it easier for me to go to my physician. If my physician says exercise more, I say, look, I'm exercising 4 or 5 times a week. I'm doing as much as I can. I can't do anymore. I'm coming to you for the extra help at this. Believe me, I'm doing my knees are doing all that they can right now. I want to talk about my knees instead of my blood pressure. Fine, we could talk about whatever. But it's great when you are doing all that you can, and you can have very engaged conversations with a physician that way.
Can you, just because we need to be wrapping up a little bit, but can you let people know how to find you?
Sure. My name is fairly unique. It's Brian with an I, Baumal, Baumal. You can Google me. My website is alivapsychotherapy.com, ALIVA psychotherapy.com. I don't have a lot of social media presence at the moment. I don't have a book to sell, at least not yet. I don't know when I'll have time to write one. But basically, you can Google my name. You can look at my website and get a lot of information from there. We haven't touched on food addiction as well. I've got information on that there, also on eating disorders that I work with too. So a lot of information on my website, and how all of those conditions relate to weight management, because eating disorders, food addiction, all come together in managing people's weight as well.
Yeah, absolutely. Well, thank you so much for joining me today. It was really interesting. And like I said, I'd like to do a follow-up topic about managing psychotherapy approaches to managing people's comments, because that's a huge thing.
It is. What I can say very quickly about that is that when I changed my relationship with food and body and weight, I strategically said I have to manage people's comments. It's one of the things, just like I have to change my eating, just like I have to change my exercise routine, I have to change how I manage people's comments. So let's do that, because it is absolutely critical.
Yeah, absolutely.
It has been wonderful.
Right.
Yeah.
Yeah, it's been excellent. All right. That was so much fun to have Brian on with me. And I really enjoyed this interview. We're in process working on setting up a date to do an interview about that topic we talked about, where talking about what to do when people make comments about your eating or your food or your body, and managing those. I think that's a really important skill, and it's a hard skill to learn, because those comments hit very sensitive parts, and it's really difficult not to have emotional reactions or to take them personally. So you'll be seeing Brian again once we get a date nailed down where we can do that interview. In the meantime, try out these tips. Let me know how it goes. Send an email to info@weightsolutionsforphysicians.ca. We'll talk to you later. Have a great day. Bye.